there's no need to introduce Madhu Pai from McGill, who will be moderating the next session.
Could we please have everyone settle down, please? So the title of this session, panel discussion, is Adapting Diagnostic Pathways to Patient Needs. There's been a fair bit of discussion in this particular conference. Even Claudia showed those slides on broken patient pathways, broken care cascades in TB, how so many people are just not even getting diagnosed, let alone go all the way to the finish line, and how we can make sure our diagnostic tools are meeting the needs of the patients best. So I want to first ask Christy Hanson from Macalaster College to come up here and give us the overview talk on the 11-country analysis that the Gates Foundation has done, looking a very detailed deep dive into patient pathways. And then after that, I'll invite the panelists to come and discuss the findings.
Thank you, Madhu. Right, so as Madhu said, the Bill and Melinda Gates Foundation nearly a year ago wanted to undertake an activity to better understand what they might do to accelerate progress in TB control at large, particularly their investments in delivery of services. And so we decided that the best way to really tackle this was to think from the patient perspective about the gaps in the patient pathway, the barriers that face patients, and try to take a number of country examples and to roll up and see if there were any commonalities and lessons learned. So with what we all already know, the 40% of estimated TB cases that are missing, we thought that the most important thing was to really try to better understand where these missing cases are and how they're seeking services, and see if we could better understand the alignment between how TB patients seek care and how services are provided, where diagnostics are actually delivered, to better understand the gaps. So for those of you who were in the WHO session yesterday, I presented this, so I apologize if there are any, I've given you new slides, a slightly different perspective, so I'll go through this a bit quickly. What we did for 11 countries was to try to take existing data, so population-based surveys, TB prevalence surveys, household expenditure and health utilization studies, census data, and to break those down and to understand patient care-seeking behavior. What I want to highlight here, and so we were asking, first and foremost, the first column, just where do patients initiate their care-seeking? Because obviously our ideal situation would be to catch patients when they first start seeking care. We know they may experience delays to care-seeking, but our study also found that TB patients are actually, once they're symptomatic, very actively seeking care. So in this, we first start by saying, are they in the public sector or the private sector? Then we look in a more nuanced way at what level of the health system are they entering care-seeking? How likely are they at that point in care to encounter a diagnostic? Just even encounter a diagnostic. And this summary slide is showing, this is an example. I'm going to come to the aggregate slide in a minute. But basically, in country after country after country, different epidemiology, different health system contexts, we found a similar story, that we usually don't get above about a third of patients who are actively care-seeking and on their first encounter will even reach any diagnostic capacity. So we took a look at, like I said, at 11 countries that represent the vast majority of the world's TB burden, and this is an aggregated slide. What I want to highlight to you is that we have, of course, we all know this, a lot of initial care seeking is in the public sector, where we tend to focus with our national TB programs, but of course we have very important use of the private sector that we try to address through public-private mixed kinds of projects, but we don't think about holistically. And then we have this other, about a third of initial care seeking that actually is happening in what we call the informal private sector. So often these are the very low-level pharmacies and these other points of entry. And what we see when we look at the probability of a TB patient across these 11 countries, TB patients who are actively seeking care, the probability that they will even encounter any diagnostic capacity the first time they go to the health system, as you can see, is under 30%. Fewer than 30% of patients will even access a diagnostic technology. So this is a rather complicated slide. I want you to focus on the upper right-hand corner. What we try to do is just say, what would we expect the system to deliver? So when someone goes to a community health worker, we don't have high expectations that there's going to be a microscopy center attached to the community health worker, but we would expect that the community health worker should have at their disposal specimen capture, sputum cups or something, and could initiate the transfer of a specimen. But in fact, when we looked at the gaps, what you see in terms of the most important gaps in that care-seeking cascade is the ability to screen at the level 0, so community care, level 1. The ability for referral is almost non-existent at level 0, which is the community, diagnosis at level 2, at level 3. So you see that the most important gaps across the entire care cascade happen in this diagnostic phase. Certainly, we have some challenges in treatment adherence and others, but the most important are impact is being limited by our gaps in diagnosis. I want to show just a couple of studies. These are not part of the work that I've undertaken, but recently published studies that just reiterate these points. So this is a study from India that's recently been published, and again, same thing, showing that even among patients who have reached diagnostic centers, the probability of actually obtaining a diagnosis, we lose people even in that phase. If we look at MDR TB care in South Africa, this is using both the WHO estimates of MDR burden and the recent IHME estimates of burden. We see that we lose, depending on the estimates you use, 31 to 40% of patients before they even get an appropriate test for MDR. If we consider latent TB care cascades, same kind of thing, and a meta-analysis showing this dramatic fall-off in the care cascade. Now, this is a study that's going to soon be released that Madhu was a part of, showing that when we ask countries at country level, even in the policy and the planning of the national TB programs, there are very few diagnostic tests that will be available at decentralized level. I'm glad this is clear. This one is flashing on the TV screen. This one is, so I keep looking up to make sure that one is not similarly flashing. What we can see from this heat map is that there are very few diagnostic tests being made available at decentralized levels. Given the technologies that we have, this is not an unexpected finding. But what we found through the patient analysis is that this is actually the best case scenario. This is what countries report as their policy, as their plan. When we dug in to find out what's actually available, it's even more, this picture is even more red. So if, for example, a country says, yes, we have microscopy at our health center level, at our medium care level, when we dug in, we found that usually that meant about 50% of those health centers actually have smear microscopy. But of course, the policy is, yes, indeed, we provide sputum microscopy at that level. The reality is there may not be electricity at that level, the microscope may not be working at that level, so it's much lower. So the key findings from this are that we have this major diagnostic gap. We know this. This isn't new to any of us. But there are some really clear findings, some priorities that I think we can derive from this. That TB patients are seeking care, not just in the public sector, but also in the private and the informal level. We've got a really critical problem at the community health level, and we all know this. We'd like the better triage test. We'd like the point of care test. But can we think of diagnostic solutions in the interim, better specimen capture, better specimen transport systems, and then a focus on what kinds of tests can we make available at level 2 and level 3, and how do we get specimens out there? So really, at the end of this, what we need is a comprehensive system and diagnostic thinking that is attached to the patient care seeking pathway, where we're thinking about testing, treating, and tracking patient progress through the cycle. So at the core of it all is our ability to have connected and linked information systems that enable us to see when and how patients are facing hurdles in getting through the diagnostic and onto treatment process, and see if we can't resolve this through our systems planning. So I'll leave it at that. Thank you, Madhu.
Thank you, Christy. I think that was just a perfect introduction for the panel. So can I now invite our panelists, Celine Garfin from the Philippines Department of Health and NTP, Cristina Giachetti from the Bill and Melinda Gates Foundation. Can we please have you up? Lessem from Treatment Action Group, Thandar Lwin from the Ministry of Health in Myanmar, Beatrice, Mutayoba, NTP and Leprosy Control Program, Tanzania, and Anete Trajman from Rio de Janeiro State University, and as well as McGill University. Folks, in case you missed it, this is an all-female panel. Well done, find. Claudia, Caterina, Alessandra, I didn't expect anything less from you. But I do feel like I'm the token male added at the very end just to make up some gender diversity on the panel. I'm sure all of you are saying, now you know how we feel when we are added as a token female to an all-male panel. So wonderful job, Find. So having said that, what I'll do is I'll also join you there, and then we'll open it up for discussion. So I don't think we could do a better job of stating the problem than what Christy has done. Whichever way you look at it, the cascade, the most broken part of the cascade is diagnosis. And interestingly, it's the exact same in HIV. When they do cascade analysis in HIV, diagnosis shows up as the number one problem. And by and large, I think once TB is diagnosed, most programs seem to be doing okay for drug-sensitive TB. MDR is, of course, off the books because we know how abysmal treatment outcomes are. And the second thing is the CARE cascade tells us diagnosis is a gap, but the pathways analysis complements it by saying where exactly are patients starting, how long is it taking, where are they rumbling in the system before they even reach the point of diagnosis. So that gives us a complementary picture. And I think the third element that's probably not coming through well is the time delays. And I think we've all seen systematic reviews from various places that it takes about 2 months sometimes to get a diagnosis of TB. Much worse for MDR because of all of the time it takes to get the result back. So my first question to you, Erica, is given that you are so in touch with patient communities, do these problems that we are identifying in the analysis that Christy showed, is that reflected in the patient's real world experiences? If not, what else are we missing in our analysis?
Yeah, thank you. And I want to give thanks not just for the heavily female represented panel, but also for starting with the patient perspective, because I think it's usually left till the end and often not given enough attention. So also a lot of credit for that. I myself have fortunately not had to go through this. So I did talk to several patients, and based on what they've said and what I've seen, doing field visits as well, I think this does map very well to patients' experience. I think an element that wasn't captured and wasn't intended to be captured is just the financial and emotional costs of this, absolutely, in addition to the time delays. And just the huge impact on people's morale and overall well-being that going through such a torturous process has, in addition to their physical health. I think, looking at the cascade is great because we can see very clearly how many people drop out, and that does really map to kind of the gaps that we've been hearing about at the patient level. I did want to just mention, too, the process that kind of Christy alluded to, which is before you even enter into the cascade, you do have to have some awareness about TB, or at least about the symptoms, which is really difficult because the symptoms are so generalized. So I spoke with Chanel, who's a doctor here, and she's representing TB Proof. And she said that, even though she sees TB all the time, she just has gotten desensitized to it. And when she was feeling really low, had a cough, she didn't even think that she had TB. She just thought it would be a flu. So I think that first step of, trying to do more to raise literacy around TB, awareness of this, and the need to seek care is really important to even get people to enter into this system. And then, of course, the people's experiences, I think, really do map onto that pathway. It's really hard to get the proper testing, and then it's really hard to stay into the system. And I talked to somebody named Lucy, whose husband actually passed away from TB. He had HIV and very clearly had a case of extrapulmonary TB that just went undetected. So I think we do need to pay more attention to some of these cases of extrapulmonary TB that might not be thought of as much, but also present a huge burden of disease. And now with tools like LAM, we could be diagnosing some of them at least a lot earlier than we are, because nobody should be dying from TB due to late diagnosis. And then, I talked to Enrique, who had a really long process of getting diagnosed for MDR-TB, and then, of course, the really long path to finishing treatment. And he talked a lot about the latter portion, which is, getting the access to appropriate DST. So some of the things we heard about in the session previously about R&D for these new tools would be really helpful if we can expedite them, because the options that we have for diagnosing this stuff is really bad. But I think, as Christy mentioned, we can do a lot more with what we have in terms of getting access to people in the field. And clearly, we're seeing the negative impact on people that the triage and falling out of the cascade of care is having. Thanks.
So just to address the financial problem, one of the few good studies that we've seen is a systematic review on what it costs for patients. And I think a striking finding there is half the total cost occurs even before diagnosis is made, which to me suggests that they have to necessarily do multiple visits with multiple providers to ratchet up that amount of money, or it's travel, lost wages, a whole bunch of stuff that goes into that big amount of money before even diagnosis is made. Do you have any other data, Christy, from the 11 countries on the cost aspects before diagnosis?
So we took in particular because we use population-based surveys. There aren't a lot that capture cost data unless we look at health expenditure studies. But we did look at health expenditure studies, and in the demographic and health studies, we systematically identified the barriers to even initiating care. And cost is the number one barrier. And sometimes when people, the top two are cost and then distance. And distance is a problem because it's expensive to travel. So actually cost is related to all of the delay in patient care, not all. There is the awareness, but once people want to seek care, cost is the barrier to getting out the door.
And if I could just add to that, one of the new targets is to end catastrophic costs from TB. And if we're serious about meeting the end TB targets, we have to be really serious about making diagnosis available and affordable to people who need it.
So before I ask our country managers also to weigh in on the analysis, can you just quickly compare, Erica, with the HIV situation? Admittedly, they have rapid tests that we are dying for. But even beyond that, is the HIV program doing anything dramatically different from what the TB services and the pathways are? What is it that they're doing right beyond the wonderful tests that they have, which allows them to decentralize the way we can't?
So I don't have quite as much experience on the HIV side, but from what I understand, I think the focus on patient-centered care has been more integrated from the beginning in the HIV field in terms of making things easier. Of course, having easier diagnostic tools helps with that, and more rapid tools, but really bringing the diagnostic test to people where they're at makes things easier. So if the clinic is a nicer place to be, if it's a little friendlier, if you have co-location of services, I think that's a lot easier. And we could actually be doing even better in TB. Both diseases have a lot of stigma, and I think that's one thing that also inhibits seeking care that we should address as a community altogether. But another portion of it is TB. A lot of these people are presenting to other healthcare facilities, and we could be bringing some of these tools into regular other places where health services are offered, maybe even in a way that's easier than for HIV, which has some additional stigma to it.
And I guess the other striking difference is counseling is always part of HIV testing, probably rarely ever done for TB, just give sputum. It's about all we probably tell people, and there's virtually nothing that really goes by way of counseling.
Absolutely. And I think that goes to the point about focusing on patient-centered care. And then also the linkage to treatment has, I think, been a little smoother on the HIV side in terms of really getting patients onto treatment right away. And we see a lot of the people falling out of the cascade in that kind of gap from getting diagnosed into starting treatment, because they have to go to different places to do that.
Okay. So Celine, can I ask you to take the mic? So one of the striking findings, I mean, not striking for us who came from the PPM subgroup this morning, but striking generally when you discuss it, is how many people seek initial care outside of the national TB program. And for those of us who are coming from India or Philippines, this is probably no news at all. But across 11 countries, sizable proportion of people are going wherever they're going. So does that align with your own understanding of patient pathways in Philippines?
Okay. So for the Philippines, based on our 2007 prevalence survey, 1/3 or only 27% of the patients are going to the health centers.
The public
So
health center.
the public health centers where we have the policies and guidelines for the NTP are implemented. So the rest would go to the private sector, to the hospitals, public hospitals, private hospitals. Public hospitals, even if they are public, they are not part of the NTP, so they don't follow the guidelines. So that's why what we did was we engaged them. So as of now, we have already engaged 90% of the public hospitals so that they will follow the guidelines. But most of these hospitals are only referring patients. They don't provide the services because they don't have the manpower, especially in doing the records and reports. So they would rather refer patients than to provide the service.
So I think this is really important that we don't discuss. We assume that all public facilities are automatically NTP or have at least a microscope available. And I think Christy's analysis shows there are lots of public health facilities which are actually not able to even do microscopy. And I think you're saying that there are lots of public hospitals that don't even offer a TB service.
Yes,
And
you're right.
not even like primary care facilities, hospitals
Hospitals.
can't diagnose TB.
They diagnose TB, but they're using usually chest x-rays rather than the smear microscopy.
So then you have to start your pathway, even if you started in the public sector, then do chest x-ray or whatever it is they do, eventually make it to a public facility, which is part of the NTP.
Yes.
And that takes time.
Yes, it really takes time, and that's why most of the patients would also not finish the pathway. They would just be going to the hospitals. Then we are not sure that they would go to the health centers unless we follow up. And we have an indicator for that. And I think that's the reason why the referral is high. And we really push the health workers at the hospitals to refer their patients. So in some hospitals, the referral rate, acceptance rate, can be as high as 90%, but for some, it's less than 50.
So if I asked you the L1 center, which we all agree where all NTPs say they have microscope, that's the primary care center, a level under the district. And we've always said TB is decentralized because at the microscopy center, we have drug-sensitive TB treatment, we have a microscope, we are okay. But we are now finding that even primary health centers that part of the public system, many of them are actually unable to diagnose TB. So let me give you India. India has 25,000 plus primary health centers. PHCs, they're called, one per every 50,000 population and so on and so forth. But there are only 13,000 microscopy centers, i.e., not all primary health centers are microscopy centers. You're also saying the same thing, that not all public facilities have microscopy center. So is one obvious solution to just ramp up the number of TB services, even within the public system, to at least saturate the L1 level with the ability to diagnose TB, or is that itself a very difficult ask?
That would be difficult in some municipalities where the health centers are, since they don't have the budget.
Okay.
So what we do, which is now the trust of the government, is we're building the service delivery network. So if that health center cannot provide the services, then where can they refer these patients so that the services can be provided? So even in our national strategic plan, we said we'll be having a TB network, wherein we will do an inventory where the health services are available so that the facilities would know where they can refer. But I know referral is not always that effective because along the way, patients will not really go to the facilities where we are referring them. So we want to be ambitious, and we said that by 2020, we hope that we can have the gene expert at the point of care. So we're looking if we can do that.
Okay. Let's move to you, Thandar. So how does this pathway analysis align with your experience in your country?
Okay, for Myanmar, it's quite interesting that Christy presented, but I would like to refer to the Prevalence survey findings that was in 2010. So among the detected TB cases, no symptoms is about 15%, but the rest of the patients, they neglected the symptoms is also high, so that patient will not come to the health center. It's altogether about 1/3 of the cases, and another 1/3, they use the self-treatment. They go to the pharmacies or just taking on their own. So that is about 1/3. And the rest will go either to the private or public or traditional healer, traditional medicine clinic we have also. So that is 1/3 only seeking for the health care. But among them, public sector is only 12%. So this is the true picture we found in 2010. And when looking back to the system, yes, we have to admit there is a gap in the sub-township level. That is maybe level 2. So we have the primary healthcare level is in below the township. So we have district and township and health center at the sub-township level. So we don't have a microscopy center at primary healthcare level.
Wow.
Although
So what is the
fertility
first level in Myanmar?
The township level we have it. So here is maybe level 2. No, township.
District is level 2.
Yes.
And level 1 is primary health center.
No. Primary healthcare is below township for us. So township is at the level 2. Yeah.
Wow.
So in that level, we
So at the village level, there is 0 TB diagnosis. Even at primary center, there is no TB.
Yeah.
It's only
primary
at
healthcare level is rural health centers. We don't have a microscopy center, but between the rural health center and township health center, we have a station hospitals. So that numbers is many.
So I think
but
your
the setup is we may have a laboratory, but sometimes not equipped with the trained human resource.
I think your experience corroborates Christy's analysis that
Yes.
even at the L1 level, we cannot take microscopy for guaranteed, certainly. Beatrice, how does things work in your country?
Yes, Madhu, thank you. I think I tend to agree 100% with what was presented on patient pathways. And I think we as, NTPs, TB programs, we have, for years been very conservative in terms of opening up for several reasons, some genuine, I'd like to give, to provide an insight to what happens to me personally. I would get phone calls or texts from my relatives frequently asking me on where either their friend or themselves could get services for TB. And this is in the urban area. But I almost never get questions or never get asked on where to get a diagnosis for malaria, for instance. In a country like ours, we have about 1,000 diagnostic facilities. Now we have reached that, the recommended WHO threshold for coverage. But in terms of accessibility, that is 1,000, almost 1,000 microscopy centers, but we have about 6,000 diagnostic centers. And 70% of our population is rural. So you can imagine the distribution of that is not, is not systematically distributed.
So since most of your population is rural, what do you think is the average distance somebody with cough would need to travel before they hit a first ability to get tested?
It will depend. It will range from somewhere between 1 kilometer to 15 to 30, depending on, 900, 1,000 microscopy center in a, huge country like Tanzania. It's not, it's not so much. And I remember when we were writing the concept note in 2014, we asked ourselves these questions. Why can't we expand? Why can't we have 3,000 microscopy centers, for instance? And we did consult with, some of the, renowned, TB experts, and they categorically, advised us that, it's better to have a few where you can control on your external quality assurances, et cetera, instead of thinking of expanding, but forgetting the fact that we are disadvantaging patients, and I think, in my opinion, for no apparent reason. And now that we are putting into that equation even more sophisticated diagnostic tools such as the expert, with the recommendation of 100%, rapid testing for presumptive cases, 70 machines. Only 70 machines available. You can imagine what is happening.
So if microscope saturation itself is low, then expert is a level higher than that, at least the current expert.
Exactly.
So access is even presumably much less than
much less. And we're now moving from the microscopy, which is already low, to an even lower available diagnostic tool.
So just to ask a question, so we know there's nothing at the village level or the community level at L0 for TB. But there are people, health workers, pharmacists, nurses, village birth attendants, you name it. Most countries have somebody at that level who's available, dedicated to do some health work. Are they asking a question? How many days you've been coughing and getting a sputum and then pushing it to the L1 microscopy level? Is that system even working in any place?
It's a good question. Yeah, so we are trying. We have things like interventions like having what we call sputum fixers. These are community healthcare workers trained on fixing sputums in places where, in initial point of care, places where patients come and there's no diagnostic facility for TB. But then the sustainability of it, that's a question, because these are people who need to be remunerated. These are people who, if you don't remunerate, they have other things to do. So it is pretty challenging.
Okay. Anete, tell us about the Brazil's health system and where diagnosis is first available, and where do you now have gene expert in your country?
Yeah, okay. So 30% of diagnoses are done in the hospitals. This is probably patients with comorbidity or with extrapulmonary TB, etc., and 70% in the primary care level. And as you know, we have the family health strategy expanding more and more. The family health strategy is a kind of primary care where a team with one nurse, one doctor, and 6 to 10 health community agents cover 1,000 families that live in this area. So the community health workers go to they do home visits, so it's an opportunity to ask people. They are instructed to ask people if there is someone coughing in the house. It doesn't seem to be very effective. And I also think that it's more than just having access to microscopy, because they do have microscopy in all centers, but I think there is a lot of missed opportunity. For instance, the patient goes to the clinic and they will ask the patient to come back the next morning with the sputum sample, despite the training and saying, no, you don't need to tell them to come back the next day. You can collect the same day, etc. For different reasons, they tell people to come back. So I think that your question about it's not only the training, it's the beliefs and the attitudes of the health team regarding all the cascade of the care. Another problem that I think that is important is the information. I'm not talking about the notification, but the information of the result, not only to the patient, but also to the health care worker. You have people dying in Brazil from TB with their result in the lab system. They have a positive test in the lab system, an expert or a smear, and they die from TB. So it's not only having availability of microscopy, it's more than that. I don't know what the solution for this is, but I know this is also a problem.
I do want us to definitely talk about solutions for the remaining of the
I
panel.
think that
But for
in
now,
health-
I'm just trying to make sure that the analysis is reflective of what the ground realities are.
Yeah.
And it does seem fairly correct that
It
the
does.
non-NTP sector, I think we all agree, by and large, doesn't quite know how to deal with TB. Certainly not informal. Most private facilities don't know what to do with TB. Pharmacists don't know how to diagnose TB. Alternative practitioners don't know what to do with TB. Faith healers probably don't. So even if we discounted them, even when they show up at a public facility, we are saying not everybody is even guaranteed a TB test. And all this ends up with this massive upfront problem of lack of case detection. So in terms of solutions, people look at all of this and the first thing they say is, let's go do active case finding. Let's go door to door. Let's take a mobile van. Let's get into the village, do everyone, chest x-ray on everyone. While it seems to me at least that there are people who are knocking on the doors of healthcare providers, formal, informal, public, private, and not even getting close to a TB test. I'm talking about symptomatic people who've already sought care and have knocked on somebody's doors and are probably going home without anything for the first few times, and eventually somebody decides to test them, and that's how they end up in TB treatment. So let's talk solutions then. Active case finding does sound very attractive, but then you realize there are fundamental problems to fix first. So, Christy, I want to start with you, since you've obviously been thinking about this. I'm sure this graphic appears in your sleep every night, right? Having thought a lot about the problem, and it does seem to match the ground realities, what would you say are at least basic fixes that we should at least start thinking about?
So I think the most obvious one is the issue of getting the specimen, not the patient, the specimen transported from wherever the patient first appears to a place of diagnosis. So I really wonder if we have fully explored how we capture specimens. We're requiring these messy sputum cups that nobody wants to transport, that are super infectious. Have we really explored the best ways of capturing? And now we can capture DNA. So have we really explored fully the best ways to capture a sample? Have we looked at transport systems together? HIV has the same problem. Malaria has the same problem. Everybody needs to transport things from the community level. They have point of care, but they still, are we thinking about TB-only solutions that we may never be able to sustain? Or are we thinking health system solutions that we might actually be able to sustain? So I think for me, that's the priority, is really thinking of system fixes that will get specimens from wherever the patients are to the point of diagnosis. And then to Anette's point, the results back. So I think the use of the information technology, the SMS phones, and all of this is such a reality that we have, this potential we have in most countries now with people having mobile phone access, even if they don't have internet, and we're not using it to get results back. So for me,
So as backward as it sounds, are you giving up on increasing the number of microscopes in public facilities as a solution?
I'm not giving up, but part of what we found in the countries where we explored is there are actually, in addition to the quality control measures, many of the facilities that don't currently have sputum or don't have microscopes don't have electricity. So maybe we have Omni coming down the line, and maybe we have, so I think there's hesitancy to keep rolling out microscopes, because then we're rolling out generators and we're rolling out. So I think we have to really think about what are the most efficient, most sustainable ways, and we also don't want to overburden health systems where the workers aren't there. So I wouldn't give up, but in a lot of places it looked like a much more difficult fix than just plunking down a microscope. It's not.
And I think
not
it's
that
obviously more than power. It's the humans to read those slides, right? That many more public workers need to be added to the workforce and trained and QA and all that. So even if Omni or whatever the next generation molecular test can successfully deployed in the microscopy center, will we ever see the kind of saturation we are looking for when microscopy itself is not saturating most public L1 facilities? How will that many Omnis appear and cartridges appear to run in all microscopy centers? So we'll still need a sample referral or a movement system, because if there are 1,000 microscopy centers, maybe 500 of them will end up with Omni or 200 will end up with an Omni. There'll still be a whole bunch of microscopy centers which will not have an Omni, so you will still need to move samples even at that level. We're not even talking about shooting it to the district level or even higher. So let's go to you, Cristina. So I know the foundation has been thinking a lot about different models of testing. And we are, I think Claudia had a beautiful graphic that if we can decentralize the test, like HIV and malaria have, take it as low as we can. For us, I think L1 would itself be a miracle if it happened. We're not even talking about L0 yet. If L1 can have a good molecular test and we can somehow make it work, that is one way to get this messy pathway hopefully fixed. Alternatively, we will still need to move samples up because we cannot decentralize everything at the L1 level, certainly not DST because there's no treatment. So how do you see this tension? And I think it's a good tension between centralizing and having an efficient sample result human movement system versus take the technology as low as possible. And where do you see a reasonable solution between these two models?
Okay. Let's put it this way. I think since you mentioned foundation, the foundation traditionally try to look for technologies for decentralized diagnostics. Yes, so had many investments in the past. They were very strong behind the GeneXpert when GeneXpert came, as well as have different attempts. Yes, with Alere. To have another nucleic acid testing instrument, have current investments for biomarkers that eventually we can transform in the easy-to-use lateral flow assay, and then we're going to have something similar to what exists today for malaria and for HIV. But we see these bring down nucleic acid testing to decentralize. The new test for rapid diagnostic tests as that we are not there yet, really. That is still time to go till we'll be able. We think it's important to keep working in that direction, but we believe that that's not the only solution. And what we see is that the solution for HIV, for tuberculosis, or for many other diseases that we need to pay attention to is to have a strong laboratory networks, a strong referral system, a strong centralized system. We don't believe that to distribute, let's say, omnis around, we just do the job, because there is a lot of needs for connectivity of that patient to the rest of healthcare. We will need to address who takes care of supply chain, procurement, distribution, optimal placement of the instruments. And all the things, we think that the best way would be to have a strong central lab with the expertise to cover a region and be responsible for what happened in the region. We are concerned about quality management, quality of the result, interpretation of the result, not to use expired reagents. Yes, there are so many details that requires a lot of training. Even if it's a test that is just collect the specimens, do one step, put on the cassette and in the instrument, it requires training really, and there are many opportunities for mistakes. And when we see visit, I don't have a lot of experience in this area, I'm just new to global health, but the little I visit and you see how busy some of these facilities are, how busy the healthcare workers are, it seems that it's asking for them to do too much. Yes, collect the specimen, be sure it's right, put it in the machine, read the result, tell the patient where to go next. So what we see is that we have to be a little realistic about how much can be done at that level. Unfortunately, I see that in many cases, there is a diagnostic development going because of a technology rather than from an understanding and what is needed and for a good delivery and access plan that needs to go before the development of the system needs to happen. So what we are trying to do at the foundation is to revert a little the point of view and think a little bigger in terms of what would be a more has a comprehensive solution. It's not going to be easy, but we think that is the way as we are going to have bigger impact, actually.
I hear you, and I think Katharina and Claudia were also mentioning there's a whole bunch of tools that can only survive in a centralized lab. Sequencing, we saw that, cultures, LPAs, the high throughput NATs that are available. We just cannot decentralize it, nor do we probably need to. But I do, and coming from US or Canada, we all are comfortable with the centralized testing. And by and large, we know we'll get the results, we'll follow up, everything goes well. But I do want to ask our colleagues from high-burden countries, what is the realistic timeframes that centralized testing can actually produce results without too many investments? So all of you have a centralized lab, whether it's your national reference lab, whether it's your main tertiary lab, they all exist in all countries. Tell us, what is the realistic time frame for a sample to go from an L1 facility to one of your centralized labs, wherever they are, and for the results to come back and for the patient to be put on MDR TB treatment or whatever? What kind of timelines are you realistically seeing in your country? You want to take that, Celine? I don't expect you know the exact numbers, but just give us a rough idea of what it takes.
Because it would really depend where the facility is and where the central lab is. Like if it's in the national capital region, then within the week,
okay,
the result can be given.
Okay.
But it's from Mindanao, the southern part,
yeah.
Then maybe a month.
Maybe a month.
Yes.
Okay.
That would be the longest, I think.
Okay.
1 month.
Okay. And Thandar, what would it look like in Myanmar? What is your turnaround for your centralized
It's longer
test?
than that, starting from 2 weeks to 1.5 months.
2 weeks to 1.5 months. Okay. Beatrice?
Yeah, I think similar time frames depending on the test. If it's an expert test, it will take 3 weeks, a month. If it's culture on solid media, the standard is 8, but somewhere between 8 and 3 months.
Okay.
8 weeks, 3 months, 4
Let's
months.
not talk about solid cultures, please. We are not at all talking about solid cultures, which is a complete waste of time. I've never seen any clinical decision made on the basis of solid culture. But even with the rapid test,
Yes.
it still takes that many weeks.
It still takes time, and I think it's because of the fact that most of our systems are still analog. We're still using paper-based. There's challenges with interoperability of the data from clinical data to the lab data. So there's a whole range of challenges there in terms of reporting and being able to transmit the results back instantly, even if the result is already at the central lab.
And Anete, just a quick response from you. What does the centralized testing in Brazil take?
The same, 15 days, I would say. From 15 days to 30 days, it's the same.
So 4 to 6 weeks.
I think it's a problem of information as well.
Okay, so let's say by some miracle the sample does reach a centralized lab. what is the likelihood that the result will come back and a patient will be found and linked to care? So tell us a little bit about not the time anymore. We all agree that it takes time. What is the loss you expect in just never able to retrace that patient and put them on MDR or whatever it is that they have? What kind of losses are you looking at centralized testing?
I don't understand your question. From
Proportion lost because of centralized testing.
results lost.
Results lost, patient not found, not traceable. It has reached the facility, but nobody's opened the fax or the mail or whatever. What proportion are we going to lose by doing centralized testing, realistically?
I would say 20%, maybe.
20%?
It's a guess.
It's a guess. Okay. Beatrice?
For drug-sensitive patients, we don't know. We believe it's not significant, because those will be initial defaulters in our laboratory registers, which are not, are not part of the NTP mandatory reporting and recording, unless we do a study. But for MDR, we know we have a gap between the treatment those who are diagnosed and those who are started on treatment of around 30%. So it's an issue.
And Thandar, what would you say your losses to look?
20 to 25%.
20 to 25%.
For the drug resistance. But drug sensitivities, I don't think we have a problem.
Okay. And Celine?
So for us, based on the 2015 data that we have, it's 15%.
Okay. So we expect a 2 to 4 weeks delay, and we expect to lose about 20 to 25% of patients with the centralized testing model without any intervention. Presumably that it can be addressed, provided we do some serious system fixes. And I think Christy's point is we cannot just fix it for TB alone, because it will probably not be cost effective if it's a TB alone sample result referral process. We might as well do it for viral load, whatever else needs to be moved up and down, and have a more comprehensive centralized testing. So Erica, how do you see the discussion that Katharina was talking about? If we had an essential diagnostic list, and if we could put TB on that list, do you think it might help countries to put some resources behind it to at least make the system work, as with HIV, malaria, and other critical tests?
Yes. I can say more. The civil society community and activist community has actually just this past week called for an essential diagnostics list, and I think this would be really helpful. We've been thinking about it from a slightly different perspective, which is related to this, but just that the kinds of tests that a lot of countries are using, some of them are using tests that aren't WHO recommended for TB, including serological tests despite the negative recommendation. But then we also see that really good testing options still aren't being taken up. So I think an essential diagnostics list would be very helpful for helping kind of make sense of the wide range of products that are out there for doing something in TB, and to make sense of which ones should be prioritized to allocate resources appropriately. It would also really help the advocacy community to be able to point to something very clearly and say, you should be using this test in this country and you're not, or you shouldn't be using this test and you are. So I think that would be really helpful.
I think essentially we are trying to see if the essential medicine list has been a useful tool for countries to make sure there are no stockouts, that there are enough quality assured essential medications available. Why shouldn't we demand essential diagnostics that are absolutely non-negotiable, should always be available, no stockouts, no import duties, supply chain is taken care of, as a way of pushing the agenda. Do you have an essential diagnostic list for Philippines? But you have an essential medicine list? Thandar, you have an essential medicine list in Myanmar?
Yes,
You have an essential diagnostic list?
Yes, I think they recently developed this, and then also free of charge list also issued from the National Health Laboratory. But what I want to say is we are the vertical program, so we are living in the different silos, right? So malaria, HIV, they have to take care on their own. Now they are successful. Why? They use the community volunteers. Not rely on the health system much, but volunteers. Now HIV decentralized up to the midwife level. So in that way, their tested number improve very quickly.
And does your country, Beatrice, have an essential diagnostics list?
I'm not sure. I know we have an EML.
You have an EML, but you don't have a EDL.
I'm not very sure about that.
Okay, and Anete? Brazil has
We have a
EML.
Drug list, but
Drug
not that
list,
I'm
but-
aware the test list. But I want to highlight what Christy said.
Okay.
Without strengthening the health system,
Yeah.
no test will do it. Because we have implemented expert in Brazil, and 1 year later, the first report says that only 20% the test was expanded to guarantee diagnosis to 65% of patients, and only 20% of them were being diagnosed with them. Some machines were never used 1 year after implementation. So we need more than a good
I
test.
can't agree more with you. And one of the reasons why we are advocating for an essential diagnostic list, that it's not about TB. TB will benefit, but it really should not be driven by TB, because it's a cross-cutting. I don't care if viral load is there, if early infant diagnosis is there, malaria should be there. Anything that is critical for a good primary healthcare system should be on that list, as it is with the essential medicines list, right? What are the critical antibiotics you need, medicines you need at that level? I think that's why we are advocating. I think TB will benefit from the list, but I don't think TB drives the list. There are obviously much more important priorities in maternal, neonatal, child health that should be on it. Chest X-ray, for example. We had a meeting in Geneva last month about chest X-ray. And I would think a chest X-ray is an essential diagnostic test. You use it for pneumonia, you use it for TB, use it for a whole bunch of things. And if it were on the essential diagnostics list, maybe countries will do something to make X-rays available. Right now, X-ray is a district-level test. Most primary care centers in most countries have no idea how to get a chest X-ray. So how will we use it as a triage test if it is that high in the value chain, right? If you already have to end up at the district level to get a chest X-ray, then I don't see it as being a triage test. If it can go down, then it's a triage test that we can use to move this forward. So I now want to open it up to the floor for questions that you may have for our panelists, and then we will close exactly on time. So questions or comments from the floor. Ellen?
Thank you. I'm going to make a comment and then make an alternative proposal. So in Cambodia, with which I'm very familiar, the stock TB people had to incentivize the laboratory technicians $1 each to actually even look at a slide, because they're paid below a living wage. And one thing that happened before I went to work for Cepheid is when the gene expert came in, those same technicians, at least in the beginning, were quite delighted to be able to put something in a cartridge and get an answer out hour later, hour and a half later. And so instead of having to be incentivized to do TB testing, like reading a smear, which they didn't want to do, they had another job, right? Everybody does their provincial country job first, and at noon they go home and go to the other lab where they actually get paid so that they can live. So this TB test, they could put it in there and come back the next morning, the answer would be there. That meant it got used about half the time that it should, because nobody was there in the afternoon to keep running. Strengthen the systems, as Christy has said. Pay the people a living wage. Hire enough laboratory technologists. God knows there's trainable people in these countries, and this will happen. It's not all about technology. It's people power. Why do we have good testing in US and Canada? Because we have a lot of trained laboratory people who are accredited, who have to pass. That's essential. We don't have that in the developing world. That's what's missing.
Wonderful point, Ellen. Anyone else has a comment? While we're waiting,
If you have a comment, you could just
could you
line
please
up
go to the mic, please? We can't hear you otherwise. Please introduce yourself, and then you can make your...
Hi, my name is Annabelle Cannabis, and I'm the editor of a website called TB Facts. But I worked in the HIV sector for 20-something years, and I've been appalled at what I've heard today. And what I would say is, where are your advocates? Where are the people? I mean, if you can't even get things done, like make sure the TB sample gets put on the bicycle or the van along with other samples. Even in England, we don't send samples on their own from a GP. we load them up with other samples. And whatever day of the week they go is the day of the week that certain things have to be done. So I think it's all eminently solvable, but it comes also under the WHO thing of know your epidemic. There's no one solution. People have got to work out your own solutions. The other the question I have is, when are you going to do something about BCG? Because I literally get emails from around the world saying, there's no vaccine. Can you get me some vaccine for our children? Please, can you do something about it?
Thank you. We definitely will not get into vaccines in this panel because we have enough diagnostic concerns to deal with. That's an easy cop-out. Aditya, you want to ask a question?
Yeah, I'm just thinking about you mentioned solutions, but what about some regulatory or policy changes? I was thinking about the difference between HIV, and you guys mentioned TB treatment happening in the private sector. As far as I'm aware, that doesn't really happen to the same extent with HIV. Right? I mean, most, at least that I'm aware, all of that treatment is sort of very directed and guided. Why is that? I mean, I'm guessing it's because of procurement and distribution rules and regulations about how those medicines are delivered. Why aren't we pushing for those types of changes in TB, which would impact the private sector, put penalties or regulations related to sort of how the drugs are distributed, but also how testing and reporting is done? Those types of regulations, to me, are much more effective, and we're seeing that with things like cigarette taxes and soda taxes and such. But we're talking about small individual solutions that need to be customized to a whole range of settings, as opposed to kind of large-scale sort of fiscal and sort of regulatory changes that could be implemented pretty quickly.
Yeah. So coming from the PPM subgroup meeting this morning, I can tell you that countries like Brazil have effectively made sure that anti-TB medications are only available in the public sector, while India, that just will not work because 80% of India's healthcare is private. There is no way the Indian program can deal with all of the TB in India. I know. And so it's possible. But even if we can get private sector to notify, that itself is a phenomenal win, let alone stop managing TB and send everybody the national TB program. And it's only now, and we heard this morning, that countries are making it mandatory for the private sector to notify, because even awareness that they exist is enough for us to figure out what the gap in the care cascade is. And that's why the Indian data got revised for this World TB report, because we are suddenly now aware of how much more TB there is in the private sector. Yes, Andy.
Thanks very much. Thank you to the speakers and the panel for highlighting these health systems weaknesses which compromise TB diagnosis and care. And I appreciate how there's a need for centralization of some of the testing and transport systems to be utilized, to be improved, to try to get this connectivity. However, there's no one-size-fits-all, there's no simple solutions here, but we should go for the most simple solution that we can. We've heard of some of the dropout during the diagnostic process from people seeking care. There being a diagnosis in the laboratory book, but the people not getting onto treatment. There's been studies in the past which have looked at this, and it's usually about 15 to 20% of smear-positive patients drop out. And these studies were done with the old case definition, where you require 2 positive smears. With a single positive smear, this is close to 50%. So there's ways that even smear microscopy, we could adapt this using WHO recommendations for same-day microscopy to ensure that if people are smear positive, they get a diagnosis that day and they get put on treatment. There's some very simple things, and we have an armamentarium of WHO recommendations that we can utilize. And it's a question of looking broadly at what these recommendations are and trying to go for some simple things when we can.
Great comment, Andy. Can't agree more with you. Yes, ma'am.
I think the gentleman just said what I wanted to say, but the asthma from Sudan, I don't think there is, each country needs to study, what's happening and find its own solutions. But incentives is the worst thing to do. The minute the development partner or the donor or the global fund leaves, then we are at square one. If a program is functioning very well, laboratories are quality assured,
the primary health care picks the cases in time, and then, they go to the next level where microscopy is done, and the microscopy is quality assured. Usually there isn't a problem. So I see the solution is in decentralization of health services. And as you yourself mentioned, when the microscopy center is not there and it's not efficient enough, then fix, or start a very strong transport system. In the Red Sea areas, it's very difficult to move with anything except camels. So we use the camels to transport the specimen to the laboratories. But I think it will be very discouraging because I saw it in Yemen. The minute they used to give incentives to the technicians, the leprosy technicians. And so we lost all the TB technologists because they just moved and went to the leprosy program. So I don't think it's a good idea, this incentive business. Thank you.
Thank you. You get the last question.
Thank you.
And Harkesh after.
It's not a question, it's a comment and advocacy. According to the discussion we have yesterday, even now this morning, the whole day, we are discussing diagnostic tools. But my observation during this conference, but also previous conference, when it comes to diagnostic tools, we have people who are doing research. We have observers who are going to the field to evaluate project and program and how to implement techniques. But we don't have the implementers, the one who are users. I'm talking on behalf of NRL people, SRL people. We have SRL sometimes coming to tell us what is advanced technology coming out. But I think we have to involve people who are in the ground, NRL particularly, representative, to be involved at the level of the country on taking decision, implementation, but also on this forum. If we account even the nice presentation panel we have with nice lady, but all are NTP manager. When we go to the NRL diagnostic problem and challenge and how to implement is these people who are facing challenge and have some solution. An example is the transport system or the referral system. When we are designing the transport system, how to have a good referral system close to the patient is the NRL people up, but how much we involve them on this technical decision. This is my observation. Thank you.
Thank you. Harkesh?
Hi, I'm Harkesh Debas from Clinton Health Access Initiative. Madhu, just a comment. I was wondering whether it might be more appropriate to frame the question around centralization versus decentralization, not as that, but more as optimized versus non-optimized networks. And I say that because I think there always will be a place for point-of-care diagnostics in places that are far-flung and hard to reach. But for others, I think given advancements in ICT, in logistics, in infrastructure, I think there is a case for greater optimization. And I'm comparing private sector lab networks in India that will return your result within the day, right?
And inform you on your phone if your result is ready.
Yeah. And within 24 hours, with no mistakes in terms of giving someone else's report to someone else. And yet, at the same place, for tests that should take no more than a couple of hours, you'll find examples where it takes more than 3 weeks to return the same results, and perhaps with a lot of mistakes as well in terms of matching of data, etc. So, just to reiterate, I think framing the question as decentralization versus centralization, I think takes away from this inefficiency, the systemic barriers that are there. And, whether you have decentralized or centralized, then I don't think so. It really makes much of a difference.
Wonderfully put. Mahesh, you have the last question.
Hi, Madhu. Mahesh Shah from Protein Logic in UK. Couple of comments and a question. I think it's a case of having a head in the clouds and feet on the ground. What I've heard today reminds me very much of a study I did about India when we're looking at agriculture and whether or not India was self-sufficient. And actually, when they did further analysis, there was a lot of food being produced, but actually, because of the poor infrastructure, the lack of roads, by the time the food got to the market, it was rotten and useless. So this reminds us that fundamentally the advocates need to say, to manage TB, we do need to invest something in the infrastructure, the things that you talked about. So I think that's kind of a key message. It's not just about diagnostics, it's also about just management, treatment, everything else. So what's the infrastructure? What are the things that we need to place which are absolutely fundamental? That's what I've heard. The question that I'd like to ask is, how much money is being spent on awareness programs? My background is also as a pharmacist, and I think that where there is public awareness of health issues created, then you bring people to the most accessible health personnel. And that's how you'll help identify further potential TB patients. So campaigns talking about various symptoms, look out for those, actually have a great impact. I don't know whether any of the countries that we're talking about have got those campaigns, and what's the impact? Has anybody measured those?
Has anyone done demand generation campaign to increase TB testing? You have TV and radio campaigns, and do you think it's been impactful, or has it not been measured? It's not been measured. I think by and large, I can summarize the experience in TB is that we do a lot of diffuse campaigns without even good impact evaluation, and whether all those posters and radio spots are actually doing anything meaningful, which is different from ground-up community health worker-based awareness that maternal and neonatal and other child health programs do, which is much more long-lasting and sustainable. So I think the TB field is a little unclear on what the value of the so-called demand campaign mode approaches are. Celine, you want to?
Madhu, isn't it this afternoon Raj presented, because we have a TV commercial on tuberculosis, but based on the evaluation, there's really not much impact. So it's very expensive, but the output is not really clear or not good.
I think our community-based health workers are our best bet, but my hunch says that they're all busy with vaccination, MNCH, because that is what pays the bills. That is where the money is coming from. And TB for them is like this annoying thing with a messy sputum that they don't want to deal with. So it's much more challenging. And I think it's important for us because even if we, by some miracle, develop a triage test, right, next year or the year after, who is going to do them at the L0 level and then refer someone to where the next molecular test is available? And what incentives do we need to create for those health workers to do this among the pregnancy tests and the blood pressures and hemoglobins that they need to get done, or the vaccinations they need to give? Erica, you want to address that?
Yeah, I think that brings up the point that runs through all of this, which is financing and underneath that political will, because everybody was saying HIV was too complicated to treat in poor countries 20 years ago. Nobody says that now. So I think, and it's, I think that people here are very concerned and all working towards the same things, but we all need to be working to get ministries of finance and to get legislators and politicians to allocate more resources and pay more attention to TB, so we can do it at every level, including the community health worker level, because we do make things more complicated than we need to be. They are a little complicated, but it's completely doable, and we're not doing it because there's not enough high-level political will. And holding a conference here in Liverpool is part of the problem for that, because how are we going to generate any political attention when we're not even in a place with an international airport or a place that affected communities can come to?
And don't even get me started that the world's highest TB burden country, India, never gets a union conference, okay? I can jump off a cliff. I've been advocating for years, and it never seems to happen. And here we are in Liverpool, Cancun, and then no India.
Well, I think the civil society is on a mission to have union conferences held more often in high-burden countries.
Yes.
But even in places that are just more politically visible would also be really helpful. And I think, with the statistics we've seen about TB in India, it's absolutely a crime to not be calling more attention with this kind of conference there. So let's join forces.
Wonderful. So on that note, I'm going to thank all of you for your wonderful contributions. Hand you back to Katharina. Thank you.
Thank you so much. This was so insightful, and I think food for thought for everyone. and we learned about diagnostics and beyond, right? So yeah, thanks to all of you for coming. Thanks to all the speakers, the panelists, and I'd like to close by importantly also thanking Alessandra. I don't know where she is, but she's really been the organizer of this event and at the heart of it. Thank you so much, and I hope you'll come again next year.